All right. Good evening to our Indian colleagues. I see Sanjeev, Prashant, and can you hear us?
Yes,
Yes, we can hear
yes,
you. Arya. Good
yes.
Oh,
morning to
How
you.
are
Good
you,
evening
sir?
to you and your team.
all
Good
right.
morning.
So let's say who else are myself, Anu on my left side, and we are our fellows here.
Okay.
We are all ready for this very
We are
complex
foro
case.
itself. Give me
Yeah,
foro.
4 we have. Yeah, so we'll just take the picture, and meanwhile, I'll just wanted to just thank our Boston scientific colleagues to continue this Meet the Master series. We did a 5 episodes last year, has been very successful. So this year we'll do 6 every other month, and try to work it out third maybe Friday, unless some other scheduling issues. And Sanjeev maybe or Prashant can tell us who else is there in our panel.
So Dr. Batra, Aditya Batra from Rohtak, Dr.
Yes.
Musin Ahmad from Bangladesh, and Dr. Mohanty from Orissa, Bhubaneswar.
Wow, very good. Good, our representation. Now, key, but the case which we webcast, we sent it with the e-blast, became unstable on Tuesday, so we had to do urgent PCI on that complex tortuous. But we actually have a equally interesting, very calcified case patient here today with a LED diagonal bifurcation. So what we are going to do is, let's while taking the picture, we just go with the slide presentation. Um, this is our learn from the master. Go inside there. Yeah. Let's get ready. This patient has a very dilated aortic root. During angiogram also was difficult. Also has aortic stenosis. So that's a little AS and but not the bicuspid valve. So this our learn from the master episode, which is disclosures none. Same. This is the episode 6. A 73-year-old male presented with new onset class 2 angina under stress. Some exertion, but usually under stress. Relieves when he calms down.
We have FCR
And
guide.
echo revealed moderate AS with a mean gradient of 20. This patient actually has multiple risk factors as shown here. And they also had some long-standing palpitation, heart murmur. As I mentioned, the mean gradient was 20 on the recent echocardiogram. Did have a stress test actually in August. And that was completely negative. So negative stress test with a good exercise tolerance, and this patient presented was controlled on good medical therapy, and actually cath revealed 2 vessel disease. There was a 95% lesion in no 95% lesion in the RPL 1995, and then multiple lesions in the proximal LAD diagonal bifurcation. D2 actually is the bigger size and has a 95% lesion. LAD has multiple 80-90% lesion, which we are going to show you. Patient had a stent, synergy stent done, and now here for the PCI. So RPL had a syntax score of 1, so still the residual syntax score is still high, 20. The question always comes, you have an aortic stenosis, 73-year-old patient, is in that gray zone. If younger patient or it has a bicuspid aortic valve, you would go for patient for the surgical valve replacement and cabbage. But since this was moderate AS and it's not a bicuspid valve, although there is a little bit of root dilatation, we felt the PCI followed by tower in next 2 or 3 years probably will be appropriate. So this is where the strategy was in this particular case, discussion with the referring physician. And today, our plan is to do a IVUS guided intervention of this calcific lesion. There's no functional test done beyond the stress test in this particular case. So it will be call it a low risk. Now, should we do anything now? But you'll see very significant lesion angiographically. Just to complete the latest ACC AHA for revascularization recommendation with the heart team, STS score, syntax, and the putting things
Also,
together.
let us
This patient has a 21 and STS score of 2.1. So also they actually have a various the subgroups, and subgroup basically coronary physiology we know is the class 1, and then recommendation for IVUS to assess lesion severity they put it 2A, so it's only FFR, but some cases we know, particularly with the left main, they say very quite clear that left main many times FFR may be troublesome, so 2A for IVUS for the left main. And then for the complex disease with the diabetic, is all that patients with the diabetes and 3 vessel and high syntax score, where Lima can be done to the LAD is appropriate class 1, and others they put it 2A and 2B. And also for the calcific lesions, as you see, 2A. Patient with fibrotic or heavily calcified lesion, plaque modification with rotational atherectomy can be useful to improve procedural success. And orbital atherectomy and balloon atherectomy laser intracoronary lithotripsy remain 2B because there is still not enough data. And then the data on the ISR, that you put a second stent, patient who have ISR, and of course other treatment, brachytherapy and so has been shown as a 2A and 2B. The hemodynamic support actually was not came up high, and hopefully with the Protect 4 trial, which is ongoing at present with these complex cases and low EF, will answer that, but that will take 2 to 3 years. The Protect trial is all on way. There are about 400 cases have been enrolled, and we had done at Sinai about 10% of the cases has been done. We are the lead enroller in the Protect 4 trial. So this basically puts it together. Another was the CTO. The CTO actually got very downgraded with a 2B, that unless it's a very strong indication, the CTO should not be done. With that note, we are ready to show the angiogram. Show the RCA. You did? Yes. Anu?
So this is the right coronary arteries. You can see that RPL stent actually.
Yep.
You see a very distal but a significant lesion is a EF, that's normal. A little hypo in the circ territory, right?
Yeah.
This is where we are with the LAD. So we normally we would like a VL guide, VODA guide, but to get a better support, had to get FCL because of the dilated route and the takeoff of the, and this is the circ. There's a OM1 small vessel, which is you can see about 60-70% lesion, yeah. But otherwise the large LPL has non-obstructive disease. So this is a dry cine. You can see tram track calcium, prox LAD, mid to distal LAD, as well as in the diagonal.
An ostial diagonal actually looks also quite calcified. Although that there is no much disease at the ostium, but disease at the bifurcation of the diagonal and goes all the way. So question always comes that in this case, we don't have a physiological testing. Should we do a physiological, or in this case, maybe identify how much the calcium is, and we can define based on the IVUS, knowing that this patient particularly had a negative stress test, so we had to be very careful that I was that if lumen of less than 3 millimeters square. So that's another way to do. Although the data does not much support, it's a like 2B indication of the non-left main deciding on IVUS for to intervene of that traditional teaching of 4 millimeters square, less than that appropriate for PCI. Although more data have come now that it is the 3 millimeters square which correlate with FFR of less than 0.8, and between 3 to 4 if there is a plaque burden of more than 70%, and that was a part of the favor trial. If the 3 to 4 millimeters square lumen but plaque burden more than 70, that's appropriate. That kind of patient will have probably FFR of less than 0.8. So with that note, I'll hear from now. Need to hear that give us the opinion. We have very extreme panelists and moderators that what would you do in this situation, in this particular case, and the whether imaging with the IFR, because patient has aortic stenosis, those cases we do IFR, although our lab is basically FFR. You want to avoid giving vasodilators, or should we just do based on the IVUS? Okay, Sanjeev and Prashant.
So I think, sir, we should go for the IVUS imaging first, and that will give us a clear insights how to go ahead with the plaque modification with Rota and 1.5 or 1.75. And then diagonal is bifurcating. That's a big challenge. In which brand you are going to end this diagnostic. This is also a challenge. Let's say opinion from all the other panelists, Dr. Prashant Jagtap.
Yeah, the question is the ostium of the diagonal looks all right.
Yes.
So should we go with the provisional strategy? That is what I am thinking.
Or should we just
Because
put a stent? Means that's a very good point. So question comes is that do we just put a stent, opening the two branches and put one stent in the branch, avoid the ostium, and knowing that we are doing atherectomy, if we do atherectomy, so hopefully plaque shift will occur less, and maybe we don't have to put a mini crush and two stent approach. I clearly say that if ostium looks good, there may be a little pinch. After we'll do the main vessel stenting, we know that it will be pinched a little bit, but that's okay. We need low pressure kissing balloon if need to be done, can be done, but that's a good point that maybe not plan with a two stent strategy as a bifurcation. I think diagonal is a good size. We definitely should put a stent, but avoid the ostium involvement. Any other opinion by Aditya, Mohsen, or Ajit?
I also personally feel like the provisional strategy should work well in this patient because the ostium is not diseased. Ostia remains apparently looks disease free. And if we are planning about the two stent, I think it will be very difficult to put a stent in diagonal because the caliber is too less to take any kind of stent. And regarding the IFR and all, I personally feel only IVUS should do well. That will give us a fair information about the morphology, anatomy, and the severity of the disease as well.
Fully agree. So that's the plan now. Yep. Yeah. More your opinion, yes. So just to say that we are planning to do IVUS now. Yeah.
I also agree with the provisional standing, but OCT can be done in these cases for to see the calcium length of the size of the calcium. Also, OCT can be one another modality of imaging. I think so.
Absolutely. So both, as you know, by the guidelines for assessment, they actually did not put OCT for the lesion assessment, means lesion prediction for the PCI. But both got 2A indication, IVUS as well as OCT equal. And this particular case, we just decided for the IVUS. But yes, as you pointed out, OCT can also be safely done. Now, only question remains. Remember this case, that after you're done with the intervention, ostial diagonal may get little trouble, but we'll see. And data have been, even for the trial of the latest one, Prepare Calcium and Rotexus, that rotational atherectomy group has a left side branch closure, which we published long time ago in 2004. So we are ready with the IVUS now. And put the IVUS on the main screen, please.
Pull back, pull back.
Yeah, now pull back in. So now it is at, I think this is
flushed a little bit. What happened?
Part.
Very tight lumen.
Yeah, after the diagonal. And looks like 3/4 of calcium here.
Loud, loud.
Oh, sorry. Yeah, sure.
Keep talking.
Yep. And this is a half calcium. And it comes, I think this is a before before the diagonal. And still there is a lot of calcium.
This is circular.
360
Where
calcium.
is it? So 360 degree? Yeah. At 11 o'clock. So full 360 degree calcium, as we saw. 1.5 bar. Connect. Yeah. Okay. So let's evaluate the IVUS once again.
Sure.
I mean, clearly the lumen is very small.
Sure.
.530 balloon. 2.530. 2.530. Yeah. So key is, in this particular case, Anu, you want to comment on the IVUS?
No, we can, I think if you see just below the diag and all that, it's about 1.5 to 2 quadrants, and just at the level of the diag and above the diag, we are seeing 3 quadrants. And the depth of the calcium, I know it's IVUS is not the best compared to OCT for analysis. It's just depth is not a lot, so we should be okay just with rotational atherectomy and balloon.
Yeah, see this now. Yeah. Circular calcium at 360 degrees. So, and you saw the lowest lumen was 1.5 millimeters in the mid LAD. So I think this is clearly, if everybody agrees, I don't think the IFR is going to do anything, give us any additional information. It's a reasonable to proceed in this particular case. Then question comes down, why the stress test was negative? Was it negative because of the balance ischemia? So that remains some speculation, but that was about 4 months ago, but I'm sure the disease was there even at that time. So we have selected the
one fiber.
1.5 rotor burr. Vessel size is what? About 3?
This is the proximal. The vessel size is 3.7.
Yeah, that's a proximal LED.
Yeah,
Yeah,
and
good.
the distal reference was a little bit small. The vessel reference was average was 2.5.
Okay.
Yeah.
2.5. Good. So we have selected.
To where the
yeah.
lesion is in the distal.
Sure. So this is a distal region.
Right there. Give a diameter
Yeah.
there.
I measure here. Single region.
No. Lumen.
Lumen, sure. Okay.
So everybody agrees now based on this with the circular, yes, can you do some other technique? And I was told that IVUS has surpassed. I thought that OCT was being done more over IVUS in India,
Yes,
but well, the claim now is that IVUS is quite popular now for various regions and of course kidney cases and so on and so forth. That the IVUS numbers of IVUS last year was a little higher than the OCT done in India. So I know that. Do you know any Jagtab or Sanjeev? I know that usually for the NIC, they will tell us the data that how many people are getting image guided PCI in India. You know, in America,
So
that number is
in
yeah.
central part of India, IVUS is
yeah.
very popular.
Yeah, let's check the speed. Okay, we are checking the speed. Yeah, good. 150, good. But roughly, if you have to guess in India, how much imaging guided PCI being done? Because in America, yeah, how much?
About 20 to 30%.
Actually, it's, you know, in about 2 years ago, it was 18% in ACC and CDR, which is all the PCIs in America. And now I was told we still have to confirm that because we just evaluated, you know, yearly when I put our data together, we get the data from the ACC and CDR comparison. Just one sec. So their number is now 27%. So 27% PCIs in America done with the imaging guidance. We don't have difference of the IVUS versus OCT. Okay. Now we are ready with.
I'm going to show the 3 steps. Okay, you have the knob with for the RotaPro. Here you go backward, forward. So any tension between the Teflon sheath and the burr is gone. And then you see that it's in the proximal LED because there's no disease. Move back. Y connector. Okay, we are removing. The burr is going backward, forward. So any tension between the burr and the wire is gone. And then the last one is on the dyna. You see that the patient is on the thing is on the dyna. It did not move. So we are ready to start burring. So it's a 1.5. So prox LED, it may be too small. The vessel, yeah. So this was selected essentially for the LED just at this level. Same slow packing motion, backward, forward, gentle, yeah. So to reach distal, what I'm going to do is go on.
No, this will be okay right now. No, this will be okay. It will reach.
To do it.
Yeah, okay. Yeah. So now we are going to do that on the dynaglide. If you to advance the burr, so on the dynaglide, brake release and manually advance. Good. So see that. So in case in the very long lesion, you advance things on the dynaglide. So that's what we did. And see, avoid the RPM drops. And this actually is our console, which we have set up that it comes the yellow triangle. If it is 5,000 and if the 10,000, it's a full yellow cycle. So if it is a full triangle means you have to slow down. So if the yellow triangle comes only with the boundaries, it's 5,000 RPM drop. More than 10,000, it comes with the yellow triangle full. So it's a visual telling you that you slow down a little bit. And if it's a red means it's stall, but stall. So which should never happen.
Okay, I'm just going to do a polish run.
Yeah. Money.
Okay,
the way the 1.5 burr is moving, sir, we need to upgrade to 1.75, I think.
No, but question comes always is that, remember now, your good point. So only reason would be that if we cannot expand. If we cannot expand the lesion. So we always say that whatever burr you had decided, that you go with that burr size and do the balloon side by side, and if necessary, then you upgrade. But you are right. So question comes in, even if burr has not done much, I say that most of the lesions, here, that it's an eccentric modification of the plaque. So as long as it has touched the interelastic lamina, your balloon will expand. And if not, so what we'll do is, we always say that leave the rota wire, get your wire side by side, do a balloon. If you cannot crack at 12, 14 atmosphere, and then you go with this, with a upper, bigger size burr. Now we actually have a 2.0 burr hole, can go 2.0 because of 7 French. 6 French, as you know, can accommodate, let's take a picture. 6 French accommodate us 1.75 only. So far looks good.
So this is our workhorse wire, which is a run-through wire. LED. Guide is out.
Huh?
Guide is out.
Yeah. So guide is a little trouble here.
Diag.
We'll go to the diag a little later.
Since we planned to do the distal LED rota, 1.5 probably was appropriate. We knew Prox LED 175 was, we needed a larger burr.
Yeah. And there was the distal, remember in the distal LED, there was a significant drop in RPM. Went up to 10,000 for a few seconds, but right away you take it out. So what happened is, what data have shown in the Stratus trial, where we use a more aggressive burr, up to 0.8 to burr to artery ratio, Stratus, STRATUS, Stratus trial. So deacceleration has to be more than 5 seconds. Nanosecond deacceleration does not count. It has to be more than 5 seconds, and that is associated with the bad outcomes. Higher CK release, higher restenosis subsequently. So therefore, as soon as you have deacceleration, you pull back and do not continue rotational atherectomy at that level. So this is a 2.530 balloon. What is that? NC? What? NC what? NC emerge. Now this is the 16 atmosphere. So that distal definitely has opened up. The question is the mid, which is our the circular calcium. We are not there yet. Yeah, this is where.
But we need a larger balloon here.
Yeah. No, but let's say as long as this expands. The whole question is that do you need to upgrade the bar? And probably not. Right, Sanjeev, what do you say now? Shine, just so that can see it.
Fairly well opened up.
Yeah, looks good, yeah.
Yeah, there is no waste.
Yeah.
So
And if you want to do IVUS, yeah.
You should IVUS, sir.
Yeah, okay. Let's say the proximal area.
It's a 2.5 balloon in a 3.0 vessel.
Yeah, that's fine.
Not done.
For the distal, this is for the distal
I know.
vessel. Yeah.
Proximal, I think before your IVUS, let's do either.
Yeah, the question is, or do the cutting balloon. So that's another point. Why not we do a 3.0 cutting balloon? Flex Wolverine, yeah. So the concept, as we are doing a trial called Rota Cut. And the Rota Cut trial basically is that rotational atherectomy, same over 0.4 to 0.5 burr to artery ratio with a high pressure balloon dilatation. Second group is 0.3 to 0.4 burr to artery ratio and then do a cutting balloon, Rota Cut. Idea there is by using cutting balloon, a smaller burr, less complication. So this kind of case, we are actually 60 patients, very imaging guided, like 4 IVUS runs in that case. We have done 48 patients so far, and hopefully will be ready for the TCT submission as it's a pilot study before Boston Scientific decide to be more aggressive, multi-center, and so just to proof of concept. And proof of concepts are 2, that by Rota Cut going up. You want to take other wire out or no?
No.
Okay. The Rota Cut that you are going to have a better lumen. The primary endpoint is ML minimum stent area post procedure, and the secondary endpoints are complications, slow flow, dissections, and so.
You see that? It's a lot of.
Yeah. Good. Okay. So this is the 3.0 Wolverine. And as I said multiple times, Wolverine you can easily go to 16 atmosphere. It will not rupture. Rated burst pressure, I think, is still 12, but you can always go to 16, 18. Is not a problem. And this happens all the time with my fellows. They go to 10, 12, and they come out. I said, no, go back and get a good effect of cutting balloon. So what do you think now? It looks good? You want to go a little more proximal also?
No,
yeah.
I think you don't want to. You're going to.
No, but we have to stand after the septal. Yeah.
Okay.
Yeah. So I think that this combination of Rota Cut.
Once more.
Huh?
Once more, it did not open.
Yeah. And then the key is the same. You bring back the cutting balloon into the guide and go back once again. Go to the 9 o'clock position. So hopefully the blade will be in different direction. Go 1 second again. Yeah.
Oh, thank you.
Little
So
more.
this is 2.5 by 10
No,
mm
3O.
balloon.
No, this is a
This is a
3O.
3O balloon.
306.
Our
306.
initial balloon that we went to the distal LAD was just a regular high pressure 3O,
No,
sorry, 2.5 30 millimeter balloon.
Go a little more,
Was a
further.
2.5. We
So
did it.
is,
Yes,
is
yes.
there any specific
Yeah,
reason
yeah.
that you have preferred a smaller length balloon for the cutting in this case?
No,
No, we
cutting is
don't have
3O.
just that.
This is a 3O.
No, length is asking.
Oh yeah,
That's the length.
oh that's
Yeah.
a good point. Yeah. So what happened is to be just using all the products. So we have that 6 millimeter is the Wolverine. We don't carry 10 millimeter, and the 10 millimeter we use a score flex. So just that. That's simple reason. So anytime we use a longer one, go to score flex or angiosculpt.
I don't know if he knows. Cutting balloon length are only max is 10 millimeter.
Yeah, that's what I'm saying. 10, but we don't carry 10. We have only 6.
Thinking long.
Yeah, no, long means 10. We because we carry only 6. For the trial, my Rotacut trial, we have a 10 millimeter also, but only for the trial. But otherwise, it's in the lab we carry 6. But you are right. If the 10 is available, you'll do a 10 millimeter here, not a problem. Okay. Now I think the rotational rotawire can come out, and we can do the imaging now.
No, you want to, what's the plan with the diag? Later? Okay. Do we image? To me looks good.
Yeah, do the image. No, I think this is a good case for second imaging.
Okay, give me. Then we just put a short stent in the diag, distal to the
Good.
bifurcation.
Yep.
You flushed it? Everything is good?
Yeah, see that on angiogram. Let's evaluate the angiogram.
Stand there. Make things are all ready.
Yeah.
Don't stand in the side.
Yeah, so diagonal looks a little roughed up.
We didn't touch it.
We didn't touch it. Actually, it's okay. That's the same boss.
If you want, you can leave it alone.
No.
Don't touch it.
Young guy. You want to leave it? It's a big size diagonal. And I can tell you, if you do FFR or IFR, that will be positive in the diagonal. Anyway,
Okay.
Sure.
put our IVUS on the main screen, please. Good.
So I put back from here. Put back. So this is a distal reference. Looks like 3O vessel. And
3O
this is
now?
a 3O vessel. And this is the most tightest part. And the lumen is also small, but
Plus
much
a little
better
bit.
than
Why this is not a
before.
good picture?
Yeah, it looks like a little bit.
We have any
dark.
cuts in the calcium?
Yeah, I saw the 2 fracture
right there,
of
right
the
there.
calcium. Yeah,
Right there.
Right.
yeah. There is a 2, at least 2 fracture.
right
this
here.
is at 1 o'clock.
Nice cut. Yeah.
nice cut. And 7 o'clock also.
Okay.
So I think Lota did a great plaque modification.
Good. So clearly, Sanjeev, you saw it, that 1.5 did make the cut of the circular at 3 o'clock position. So very nicely, cut has been done. And let's wire the diagonal.
No, but let's ask them. What is the plan with the
Yeah,
diag?
no, idea was just a stent across the provisional balloon and of the diagonal, one of the branches. Yeah.
No,
What is the
once you
size of the diagonal?
At least 2.5.
no. If you go to the diag, you need to stent it.
No, we have to stand, but our question is
Keep away
beyond the
from-
ostium. Yeah. I think the lower branch is a bigger branch. We can take a 2.5 15 high pressure.
I think diagonal ostium is disease-free.
So far looks good, right? Now let's see on the IVUS. Can we see the diagonal ostium on
Yeah,
the IVUS?
this is a
No?
diagonal from 4 o'clock.
Oh, okay.
And yes, and I think there is no disease at the ostial level of diagonal.
Looks okay, right? Ostium?
Yes, yeah, this is 4 o'clock coming diagonal.
Yeah. Okay, ostium is good.
Yep.
Which looks like angiographic also.
The diagonal is good for the DCB balloon for diagonal.
Yeah, that's a good point. Actually, we don't have the DCB balloon here. That's an excellent point in this particular case. So you want to get away, not put additional metal. If the DCB is balloon available, it's a beautiful case for the DCB. As you know that we have a lot of trouble of DCB in America because of the peripheral DCB having higher mortality. So FDA was very strict. They just allowed 2-3 companies to come with the DCB, and most of them are for the ISR so far. So will be part of one of the, we are getting our paperwork ready for the DCB, but that is for the ISR so far. There are some other company also in United States have introduced for the side branch intervention. So like this is the ideal case for it. And I don't know exact protocol, whether it's a stent versus DCB or balloon versus DCB, but for the ISR, it is basically the registry. So I think for the drug-coated balloon probably will be here in America maybe by 2000 end of next year. But right now it's still not available. It's still very experimental. Good. Ready? It's a 2.5, 15. Okay, this is the 12 atmosphere.
Okay, down.
So basically what I do is you crack and then you go a little half of that. Idea there is you tack up those cracks if you want to just do the balloon only. So question also comes, if looks okay, it's not a drug coated balloon, but if looks okay, that do you want to just leave it and not make it more complicated in this particular case who has aortic stenosis? Yeah, that's good. If we do, then the second branch will be gone. Top branch. What do you say now?
Yeah, it looks good with the same balloon.
Then we leave it. I could tell you this is the Sharma PTCA equivalent stent. That is, you go inflate your balloon to 16, 18, whatever atmosphere to full expansion, then cut it down to half. Leave it for about 60 seconds, will give you a good results. Theory behind it that you crack the plaque and with the lower pressure, you just tack it up. So a little longer than usually 5-10 seconds. Okay.
Why you here?
Yeah. Which stent? Let's just start with now.
What's okay? We put a.
So I think we'll leave it. Yeah. 2 point. We have
a synergy.
Yeah. Synergy. Yes. Yeah. So 2.75 or 2.5. We need two stents here.
No, but distal reference you said is 3.0, right? LAD now.
This reference average is 375.
Yeah, I think 2.75.
please.
Let's get a 2.75 32 and 3.0 28. Right? Good. Let's get a 2.75 32.
38.
38?
Yeah, we cover. So you'd know double at the level of the diag and put a shot. You're saying you want synergy?
Yeah.
Okay, then if it's synergy, then put 48.
They're getting it.
Oh.
No, but no, not 48, not the proximal. The 48 will cover. 148 will cover. What do you think?
No, 48 will not cover it.
Yeah.
You will need like a 12
So
millimeter.
So I
extra.
think we put a 2 stents.
Okay.
Yeah. We definitely need a put.
So it will be easy to deliver.
Yeah.
Okay.
Right there. So we are going to use a 2 stent, 2.75 from the distal to the angle. Yeah. 32. What do you have? 32.
38.
38. Okay. 38.
48. About the hot.
This is the synergy actually.
Normal size, neither size of the stent.
Yeah, length or breadth? Yeah, here. Breadth, you saw that about 2.75 average.
But length?
Yeah, length, you want to calculate the length of the lesion?
Sure. So the length of the lesion is from distal reference to the proximal reference is 42 from IVUS.
So I can use the 48.
Keep going. Yeah. Yeah, no, we are talking about from the distal to the proximal, all the lesion length, both small, distal as well as, to me, I think, tell you the angiographically, it definitely looks, actually this is 38. You want to go a little further? Or
No,
you want to
you
just,
don't need. Okay, some die. Yeah, that's why I said 48.
so no, but
48, okay.
no, you need 2 millimeter further. Then we can just put a one shot proximally.
Okay, some die. I went down. Then you're good.
Good. Okay. No, not yet.
Not yet.
So wire can be left inside for the time being. So this we are deploying at 16 atmosphere.
Don't do 16.
Not 16. 2.6. You wanted a 3.0 here.
Not me.
Huh?
No. Angiographic.
You want to do a little distal massage?
No.
Okay. You want to take a picture?
Okay. Ready. Beautiful.
Looks good. Good
Okay,
size.
so I'm going to remove the side branch now.
Yeah. Yeah. Diagonalizing wire can come out safely. Now we can take a 3-0,
12, right?
12.
3035.
Huh? No, 3-0. Vessel was 3.25 or?
Yeah.
The proximal reference vessel size was 3.7.
Okay, then you want to
forget
put the 3.5, 12?
No, actually 275 itself looks so big.
Yeah.
I think 3 is
3-0.
good.
3-0, 12 or 16? Yeah.
You want to
3.5,
cover the
16.
septal?
No,
We are going
no.
to be below the
12.
septal.
Yeah, 12 is good.
12. And then we IVUS. That's it.
Yeah. And then we do the IVUS. Yeah, and we also learn if your angiographically side branch looks good, don't go after with the FFR and all those of no additional value, rather create more trouble. So in this case, usually we give vasodilator of the nitroglycerin, but here because of AS, we'll try the calcium blocker like verapamil and so. Huh?
12.
12.
IVUS ready again.
Sure.
And we can ask any the questions by our audience in the chat box if they have any other suggestion, any comments, any questions.
Some
16
die.
would have been a better choice because we are ending in the plaque in the proximal segment.
Some die.
Yeah, right?
What?
No, that's good.
Yes.
Yeah,
No, we
yeah.
wanted a below the septal.
Yeah, just because of the septal. Yeah, I think it's
It's a large septal. And that's
an overlap will do. Good. 12, yeah.
okay. Good.
Want more?
No,
12?
no.
Okay.
Diag may go down.
No, we are just before the diag right now.
Okay, ready?
Yep.
Ready for the IVUS?
Yes.
Good.
Good.
Yep. So far, so good. We call SFSG. So let's ask maybe a audience, will anybody decide the diagonal now based on all the trials which we have at present to decide based on the FFR of the diagonal or just leave it alone?
Well, I think we should leave it alone.
Yeah, good. Other panelists?
Yes, I think
At the most, we can consider
Good image
opening
flow
the studs and doing a low pressure kissing balloon dilatation if we are thinking about, because this is a good size diagonal.
Right.
So we can just think of doing a low pressure balloon and opening the studs towards the diagonal.
Okay, that's one strategy. Good. Okay,
So
put
this
the
is
IVUS on
outside
the
of
main
stent.
screen.
I start per back.
Dr. Sanjeev was commenting something, but he's mute.
So still.
Sanjeev, you are
start
saying
to the
something,
stent.
yes?
Yeah. The diagonal ostium on IVUS was quite open with no plaque at the diagonal ostium. I think this result is quite good. We need not to go for the kissing balloon inflation at the diagonal.
Okay.
And stent was well expanded, circular, and
When the level of the diag, tell us, okay?
sure. So not coming the diag, still not coming.
Yeah.
We'll be
So,
there
yeah,
shortly.
stent is well expanded. I can't see any diagonal yet.
Diagonal is
That's a
already
diag.
gone.
That's
We
a
already-
diag. Yeah, we finished.
Okay,
we
sure.
finished. We saw it a little bit
Sure.
behind. Yeah. Do we need to post here?
Yep.
Looks good.
Yeah, it looks very good.
You want to post there? 3, 5.
I'll find the diagonal level later.
Well,
This is a large septal, and
okay.
this
Very
is
good.
proximal already. Yes.
Yeah, so
I'll stop there.
proximal, so area, the Sanjeev, as you mentioned that should have gone a little proximal, but I think our goal was to just keep the septal unjailed, although probably will not be a major issue. But you saw that the good lumen, little bit plaque only with the proximal edge, so it's not an issue. So let's just go back, our concentrate on the diagonal, which is the bigger issue.
Sure.
And do we need to dilate at the level where there was a full circular calcium further with a high pressure balloon dilatation? Those are the two questions we need to answer now.
Angiographically looks good, but in IVUS,
Yeah.
I think
There.
we need to post it,
Right.
right? No, you're come back.
What is this guy's name?
Shingo.
Yes.
Shingo,
Yes, I'm
go
checking.
to the area where there was a circular calcium
Yes.
earlier.
Proximal LAD.
Proximal,
Okay, sure.
proximal to
Not
mid segment.
I mean
Yeah.
proximal region of the stent.
Yeah.
Just close to the septal.
Yes, here's the 360 calcium outside the stent.
Okay.
And
And how does the stent actually looks okay here?
Yes.
Or should we make it more circular by using the
I measure
bigger stent? Is
area
it 6.5 or
Yeah.
no? It's 5.2.
5.2.
I think we can use a 3.5 balloon because angiographically little dent here. See that now? Angiographically, this is where we are.
Angiographically is beautiful.
Yeah. But
Dr.
lumen is only
Sharma,
5.5. Yes.
Dr. Sharma, a question. I'm Dr. R.K. Jain.
Yes, RK.
So, the IVUS showed that it's 3.5 proximally. Okay, when the landing zone is there, but you still went ahead with the 3 millimeter stent.
Right. So no, that is true. So that's where we are discussing now. That should we dilate with a 3.5? That is correct. So key is we know the stent is opposed. Question is it stent fully expanded? Those are two different things. Opposition and expansion. So opposition is good. Do you want to, since the vessel was 3.5, do you want to make it better proximally? That's the question. Absolutely, what we exactly are discussing. That should you expand it further, knowing the lumen still is only 5.5 millimeter square. You want at least 6.5 in this case. Although by criteria of the optimal IVUS, they mentioned that once your lumen is 5.5 is okay.
Okay, give us high pressure balloon.
Yeah, and Dr. Sharma, again, Dr. R.K. here. So again, the distal LAD, the distal he said, the IVUS person said is 3 millimeters. So, but still he used 2.75.
No, actually, average was 2.75, isn't it? Distal. Shingo.
Yes.
What was the distal vessel?
Okay,
Let's
I'll
go back
measure it.
here. You see it right there.
Yes, I measure here.
This is not the distal. Is this distal?
Yeah, this is a distal. This is distal.
Now
Yeah,
3
this
plus.
is a three.
But look at the angiogram. I know we are trying to do, even in it looks,
It looks like average.
More negative remodeling already, minus
Yeah.
10% angiographically. But I was, yes, once you're using the data of the imaging, you have to have some. So I think to me, knowing that the distal looks quite good, we go a little more aggressive, may cause some perforation. So it's nice expansion. But yes, this area of the proximal, and particularly you want to go 2 millimeter more, because that's where the circular calcium was. Yeah. So we just go with a moderate pressure with a 3.5 at 12 atmosphere. Yeah, so question always comes that do you follow the IVUS lumen completely or the angiography or in between? So we know that with the OCT,
Hi.
yeah, 16. Yeah, that for OCT is always looks the 1 millimeter smaller. Yeah, that's it. Okay, I'm going up here. And good.
Okay. Come back here, SS. I don't know if I caught the.
Okay, you want to see
proximal
the
edge.
stent zoom, that proximal edge being done?
No, I can see it.
Zoom, yeah, zoom. We'll do the zoom. Stent
No,
boost.
you can't.
Stent boost. 1 second. We'll do the stent boost. So just want to be a proximal area. You want to make sure that fully expanded. Yeah.
There are a few questions in the chat box.
Sure.
Why not keep the proximal stent before the septal, as now there is some heaviness before the proximal stent edge?
Okay. We'll see. Well, there is a mild plaque there. That's we know.
Okay, go to the proximal.
Yes, I measure the area.
Good. Okay. Stent boost. Do it.
We don't see it, Pablo.
Not to Sine. Isn't it?
Wait. You don't see. You should see it there.
Yeah, right there. It actually is good there.
Yeah. Okay, go up.
And the overlap is separate. Yeah.
No, they can't see it.
No, you know. So, no, yeah. 16, good.
Okay, good.
You want to go overlap a little more again?
No, we're good.
Okay. Yeah, so but let's see this now. We are going to take some pictures. Okay, what are the other question? Yeah, there is a mild plaque, which is okay.
So,
Good. Take the wires out and so there is a mild plaque there in the proximal LED.
The guide may come out. Okay, ready?
Let's give Barab a little bit.
No, nothing.
Okay.
It's good.
So one more question is, if on IVUS one doesn't see full stent expansion even after
Yes.
multiple post dilation, at
Yes.
what percentage you will be comfortable to stop dilating?
Yeah. So very good point. So I think the same. You get a lumen of about in a 2.5 millimeter vessel of 4.5 millimeter lumen. Little bit dent, 10%, 20% leave it, because furthermore you will be cause perforation. In a 3 millimeter vessel, you want to have minimum 5.5 millimeter lumen square. So this case is definitely 5.5 plus, and the proximal is because of the little plaque proximally, so that can be left alone. So mild disease, not unexpected. So question is, even with a mild disease, should you cover all the area? Will it lead to a additional long stent length? We know that diabetic particularly will have a little trouble. I think the mild, and we have the intravascular ultrasound, good lumen proximally, and therefore we left purposefully the proximal area. And you want to comment on final on this?
No, I think everything has been
We
well
could have
discussed.
covered with a one single 40 millimeter stand, because we have just done a 12 millimeter of stand with just a little bit of overlap. So we could have covered with a one single 275 or 3 millimeter 48 length with synergy.
Yeah, so that's a good point. So 2.30, we thought the distal vessel that definitely is not a 30, but 3048 would have been fine. But then 2.75, and then you take you to 3.5. All the people say you can always increase by 1, but our practice is that you don't go beyond 0.5. If you require 2 stents, that's okay with the minimum overlap. But yes, if you would have been a 30 across, and then you proximally dilate with a 3.5 would have been reasonable also, yes.
No, I mean it's okay. We could have taken a 3038, go low pressure.
Even 48.
Deploy it, 48. Deploy it 10 atmosphere and then post dilate the proximal.
Yeah. That's another view.
Yeah.
That deploy at 10 atmosphere and post dilate. So I think the question is, could we have done this case with a 1 stent? Answer is yes.
Yeah.
It's just a little different practice pattern, but yes, it can safely be and fully done with a single stent also.
So any comment and inputs from all the esteemed panelists? Dr. Prashant, Dr. Aditya.
I think putting the 2.75 stent was the right strategy, because it was deployed at 16.
Yeah.
And we don't want to perforate. We don't want to, that is media to media. That is the maximum you can go. When we measure, the lumen, it was not lumen to lumen diameter. It was media to media, and that is the maximum you can go. So 2.75 was the minimum lumen. So media to media. That's why 2.75 was the right choice, I thought. You have to be a little less aggressive with the disc-made LED. Otherwise, you can cause perforation.
Yep. And as you remember, all the trials of the IVUS, long-term, better results with the IVUS, but acutely, you require more balloon, more stents. They all have shown. No one has shown that by doing the acutely, that you have with the IVUS, you have a lower complication. So it is basically a key remains is that the go with the kind of in-between approach. And I have seen it many times. We go to the media with the stent, and we got a little extravagation, in some cases even perforation, but little extravagation, as Prashant just said.
Yeah, Dr. Girish from Apollo Bangalore has joined. Let's have his.
All right, Girish.
Pleasure meeting you both, sir. You're great artists. I just wanted to ask you, in your opinion, how the Rota Pro has made a difference?
So very good point. So question is now, actually they are not going to make the classical Rota, and now the Rota Pro, biggest thing is to me that it stabilizes your RPM. You don't waste time of adjustment. The console comes with a 160, 155 RPM set. Second, it's a more visual cue of the 5,000, 10,000 drop RPM so that you can stop. So this is the additional point. The single triangle, 5,000, the brown triangle, full brown triangle is a 10,000 RPM drop. So it means you to be a little careful. Key is because deceleration for a more than 5 seconds has been correlated with subsequent bad outcome in terms of higher CK release and restenosis. We actually, one of our project with one of the fellow, we switched in 2018 from July to October time frame. So what we are doing is comparing our rotational atherectomy data of 2016, 17 and 2018 June, followed by from 2019 to mid 2021. So all 2.5 years pre and post RotaPro launch. So does it make any difference in terms of outcomes? You will know it because we are working on this project. So my gut feeling is we did have some trouble in the beginning, that the little burr, it was less resistant. So then we went back, I went to the factory, we changed it because it was very low resistance. The burr was just going very easily. So we changed all of that. What you are seeing now is like a RotaPro 2.0. There have been multiple changes before you is available at present. And now this is actually, we are not seeing any more burr stuck. In the beginning, we did see some burr stuck. And so, but whether it makes any clinical difference need to be seen. But I can tell you one important thing with the RotaPro is that deceleration is less happens and it makes you more vigilant. That's it.
Excellent. I just had another question, sir.
Yeah.
Now, if you have a very proximal LAD lesion, which is a longer, very narrow lesion,
yeah,
would you go by 1.5 first and then upgrade to 1.75, or directly are you going to go through 1.75?
Yeah. No, you want to answer that? Yeah.
Yes.
No, if you're going with the imaging, right, though there is no data saying how based on the imaging we have to do is what we do. I did ask him, remember there was a question, should we have used 1.5 burr or 1.75 burr in this particular case? And the distal LAD, based on our experience, having done thousands of cases, we said we'll go with 1.5. But if somebody is learning and they want to use imaging, Shingo did do the diameter at the distal LAD and it came to 1.5. So also important that yes, we are doing rotational atherectomy and the burr has to do a job. It has to do some, calcium has to be chipped off. So your question is, can I do 1.5 or 1.75 burr? So if it is very tight, more than I would say 80-90% lesion, proximal LAD, even if it is 3.5-4.0, I think it's okay. If it's a long lesion, go 1.5. And if it's a short lesion, you want to try 1.75, that's okay. And now your point is, can I do 1.5 then go to 1.75? And our own experience as well as we have published that if you want to upgrade, try to go 0.5 burr. Other than that, it will be a waste of doing atherectomy. So it's, if you use 1.5 and like I think we showed here, you do a balloon and see if it's not expanded, you want to do rotational atherectomy again, the next burr has to be 2.0, not a quarter size. Yeah. Not quarter size, has to be 0.5. Yeah.
And that's a very important point, and we wanted to point that out. While you are doing this balloon dilatation, your rotawire is still there. So you're not worried about recrossing. So rotawire there, you brought your workhorse wire, you dilated with the balloon, did not expand, then you go. So the question is, then can I combine with IVL? Rotatripsy. So a lot of people will think about that is okay, good strategy too. Maybe that will have a little lower complication because we know that bigger the bar, more complication. So that is where the rota cut, my concept is that small bar along with a cutting balloon. So key is that how we can get our rotational atherectomy, and I always say that it may be even you using the bar similar to the lumen, but as long as it is going to make some eccentric cut in the plaque. So that is all you need, because ultimately you just circular, you saw that in this particular case, the circle was interrupted by the 1.5 bar. It probably didn't do any plaque debulking, but just interrupted that, and therefore then stent expanded so nicely. So just to say all to everybody that long lesion, decide your rota burr size pertinent to distal vessel, keeping it about 0.4. maybe even lower, but 0.4, because we want to have a device which have a least complication, but yes, improve our procedural success.
You want to tell them that what do we define a long lesion?
Yeah.
We used to diffuse more than 20, but now recently there is data from trials saying that the length, anything more than 27 would be long. So that's where if your lesion is long, try to go, smaller burr, because there's a risk of what is the biggest, why people are worried about doing rotational atherectomy in calcific lesion is to avoid slow flow, number one, dissection, number two, and very rare is a perforation. Yeah. So
Great.
So
the distal vessel diameter is about 1.75 or 2. Would you still take 0.7 or 0.8% of the vessel diameter, 70-80%? Should we go till there? I saw one of your case, madam, even you had done up to PDA. So when you're going distal and distal, so would you still be comfortable with 80% of the lumen diameter for the bud ratio?
Now, very important, it's a 2.5 and our smallest burr is 125. So there we may be, yes, we may be a little over, I would say oversized when we go to burr, but because that's the smallest burr that is available.
Yep. All right, Sanjeev.
Many times we do make a point that we probably need a 1/0 burr.
Sir, for practical purposes, as you are talking about a rota cut, like maybe because of the cost constraints and other factors, we can't use cutting balloon in each and every case. So for practical purposes, what do you suggest? Where should we use a cutting balloon, or we just go ahead with a rota, then do a high pressure balloon dilatation, non-compliant balloon, and then look for the need for the cutting balloon? What do you suggest about that?
So very good point. So I would say that once you have a large vessel, 3 millimeter, you have circular calcium more than 270 degrees, and you use a 1.5 burr. So burr is about less than 0.5. So now we know that this may give a trouble ultimately for a full stent expansion. In that case, I will use a cutting balloon. If it's a 180 degree calcium and the vessel size was 2.5 or 2.75, just go with a high pressure balloon dilatation. I think it's a strategy. Whether this strategy makes sense or not, there are some data. The rota cut has a lower complication and lower restenosis that follow up compared to the routine rotational atherectomy, but those were not randomized. Those were from the study published in Journal of Invasive Cardiology from Germany. So this is some concept there that by combining two, you may have a lower complication and lower restenosis that follow up. But I will reserve that statement. But I would say that by and large, after rotablation, do a high pressure balloon dilatation. If you opened it, you are done. And just put a stent.
So could we say if you have a long diffuse disease and we need to do rota comparing to the distal vessel diameter, the smaller rota burr, so the proximal artery could be dilated with the high pressure cutting balloon, because we actually have not done anything to the proximal segment.
That is correct. That's but I would not say that we did not. We probably created a small gutter. But you are right, may not have the visible, but we might have created a small gutter. But yes, in that case, it's a reasonable, as I mentioned, that with that 3+ millimeter, using a cutting balloon after the rota will be appropriate. All right, so we are exactly at the 9:30 time frame. Yes, Sanjeev.